Good afternoon, and welcome to Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet, and the audio function is on, and the volume is turned up. Please make sure your microphone is muted for the duration of the call. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman Bridges and Susan King Lanier. For closed captioning options, select the closed caption feature located on your dashboard. To adjust the video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions, an MHSU IDD TBI system announcements and updates. Our topic today is the Rural Health Transformation Program. A panel discussion and Q&A session will follow the presentation. At this time, I would like to turn it over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you so much, Dina. Hello, everyone. Kelly Crosby here. It's great to see you all today. For those of you that don't know me, as Dina said, I'm the director of our Division of Mental Health, Developmental Disabilities, and Substance Use Services. I've been at the department actually almost 15 years now, and I've been in the field for about 30. I'm a licensed clinical social worker, and I'm a person with lived experience. So welcome today. So today, we're going to cover something that's a little bit different. For those of you that attend Side by Side all of the time, what we like to do is give you updates on strategic initiatives that are happening, as well as important things that are happening with state and federal funding. There's been a lot of those kind of announcements lately. But today I'm going to go through some really important things in our system first. I'm going to do some quick system updates, and then I'm going to invite folks from the department. So I'm really excited to have a lot of my colleagues here today. And we are going to talk about a funding opportunity from the federal government. Hopefully many of you have heard of this funding opportunity already. And when you hear the information, think about it quite broadly, right? This is for rural health transformation. That can be inclusive, of course, of mental health and substance use, but it's very much healthcare, rural hospitals, rural access, innovation in those areas. So it's pretty broad. So we're going to get an overview of the federal funding opportunity. There's going to be a panel of us discussing it. And there'll be time for questions and answers. But I want you to understand that we know today is a really big session. There are hundreds of you on the call. So please think about this as an overview, a chance to throw out some questions. Even if we don't get them all today, it will help us to understand the types of questions you're having so we can tailor FAQs and make sure there are other opportunities and you know about the opportunities for asking questions and also giving us feedback in the future. So look for that information throughout today's presentation. But first, I have to give some system updates. So if we can go to the first slide, there's a lot of really important things happening this month. And I actually spent the morning in Greenville. It was truly wonderful. I just got back to my desk. It's 988 day. I don't know if you know that. September is the 9th month. It's the 8th day, so it's 988 day. We were at the Real Crisis Center in Greenville. Remember, they operate 988 across the state. We had an amazing celebration. So we were celebrating the 2-year anniversary of the video phone line for individuals who need American Sign Language, individuals who are deaf and hard of hearing. We had folks from the Veterans Administration come and talk about the veterans segment of the line and veterans who've received help and it saved their lives. We had an individual come and talk about how the line saved her life. So it was truly an extraordinary celebration today. So it's a really good day. That aligns, of course, with it being Suicide Prevention Month, which is really, really important. And hopefully folks have been tracking the release of our new Suicide Prevention Action Plan. We released the Black Youth Suicide Prevention Action Plan a few weeks ago. Incredibly important things. 988 is incredibly important for our overall strategic plan to reduce, and can I say it, someday eliminate suicide and self-harm. So really important, really, really important week. The governor proclaimed it Suicide Prevention Week. Another proclamation for this week, it's actually Direct Support Professional Recognition Week. So there's a governor's proclamation out on that today as well. We just celebrated, or we began celebrating last week, National Recovery Month. I've got my purple nails on for National Recovery Month. As a reminder, it's actually here on my desk. North Carolina won a big old recovery award. I was in DC last week to get that reward, so congrats to all of you. It's also Deaf Awareness Month, and it's FASD, so Fetal Alcohol Spectrum Disorder Awareness Month. So really, really, really busy month. We'll be joining with partners throughout the month to celebrate, in particular, 98-day suicide prevention recovery months and lifting up our direct support professionals. There'll be a panel later this week or later this month where we lift up direct support professionals. So a lot of information I'm cramming in a really small segment. Really sorry, Susan. I know I'm talking way fast for your interpretation, but there's a lot to cover today, so I'm being really quick. All right, the next slide, please. So just a reminder, y'all, another really big slide, but remember, it's perception of care survey time. So providers, there's a hot link on here. Please give the perception of care survey to any of the folks that are receiving services and supports from you if they are willing to take the survey. The survey is really, really important. We really want to understand how individuals are experiencing the care that they're receiving in North Carolina to see if there's ways we can help. We all want feedback so we know how we can make our system stronger and better. Last year, we had great response to the survey. And this year we're a little behind. So just wanted to encourage you all to please get the perception of care survey out to folks that you are providing services and supports to in the community. Next slide, please. We just published, and it's really cool, and we sent out a special hot topics. Our new Inclusion Works strategic plan was just published. So really, really proud of this, proud of the partnership with the community to create this strategic plan. It's all about helping individuals with intellectual and developmental disabilities understand the choices they have to work in whatever setting is most appropriate for them. And for those who choose to work in the community, we are working collaboratively to make sure that people with IDD are a valued part of the workforce. They can get a job with people of all abilities. They get paid at a fair wage, get the same benefits and opportunities for advancement as anyone else. That's what competitive integrated employment is. So this plan is all about offering choice and honoring choice, and then making sure for those who want to go into competitive integrated employment, we do our level best to make sure they have all the services and supports they need from our division, but across the department, like EIPD, vocational rehabilitation, as it used to be called, just making sure folks are able to access all the supports they need to have fulfilling and exciting careers if that's what they so choose. I want to mention too, there's also in the plan, and we've been doing a lot of partnerships with providers who provide things like supported employment, job coaching, job readiness, job development in the community, because we want to help those providers who are doing a fantastic job do an even better job, innovate the way they do care, and make sure that people also have access to things like transportation, which is a big barrier when folks are trying to get jobs. Next slide. You're going to see more about this, so I'm going to be pretty quick on this one. Hopefully you've seen some of the announcements that we launched our new Ikiru pilot. It's really tricky to say, y'all, Ikiru. It's a Japanese word. It means to receive. This is a voluntary pilot program where we're working with PRTFs in the state of North Carolina to reduce seclusion and restraint. So it's a de-escalation model. It's coaching for staff. It's new tools and equipment. And this is voluntary, and every single PRTF in the state, all 22 sites raised their hand and said they want in. So this is really exciting. You will hear more about this. We'll be visiting the sites. And this is just part of our transformation of the PRTF system here in North Carolina. Remember, we're trying to make it super therapeutic, brief, healing, and we want kids to get back into the community as soon as possible. So we're working to change the culture and the clinical services that are provided in residential care here in North Carolina. So stay tuned for more information. And I think we have one more slide. Yes, remember, it's Suicide Prevention Week per the governor, but it's also Suicide Prevention Month. Remember, we released our Black Youth Suicide Prevention Action Plan. We're super excited about that, super proud of it. This is a partnership with North Carolina communities. As part of that, we have our Stronger Together conference coming up in Rocky Mount this month. So here's information. You are welcome to come. This is a community celebration. I'll be there. Hope that you can join us, but wanted to share information about the Stronger Together conference happening in Rocky Mount. Next slide. All right, so here's what we're doing today. I already told you at the top of the hour. First, we're going to have Jonathan Kapler. I know that you all know Jonathan. He is the Deputy Secretary for External Affairs and the Chief of Staff here at DHHS. And if you know Jonathan, he's just marvelous. He's brilliant, marvelous, really good, thoughtful, clever human being. And he's going to talk to us about the Rural Health Transformation Program. He's going to outline it for us. So he's going to do that first, and then Jonathan's going to facilitate a panel. So I will be on that panel. Melanie Bush, who is the Assistant Secretary for North Carolina Medicaid. I know you all know Melanie. And then Maggie Sauer, who is a dear friend and just has been in the rural health world forever. She's the director of our Office of Rural Health, if you do not know Maggie. So we've got rural health experts, Medicaid experts, and of course, Jonathan, who's experts at all things policy. So first, Jonathan is going to explain the program to us, and then he will facilitate some question and answer time with Melanie, Maggie, and I. So I'm going to turn this over to you, Jonathan.
Thanks so much, Kelly. It's good to be with you. And I don't know if I'm going to be able to live up to that height, but I'm happy to try. So we can go ahead and dive in. So this is the background on the Rural Health Transformation Fund or Rural Health Transformation Program. This was a bolus of money, $50 billion, that was appropriated by Congress through the reconciliation package or HR 1, as we've been taken to referring to it. And a couple of key facts associated with this. Number one, the $50 billion is really two $25 billion chunks. And this is $50 billion in total for the entire country. And the first $25 billion is being distributed to every state evenly over the course of 5 years. And so North Carolina is guaranteed, just like every other state, to get $100 million for a year for 5 years. And so that alone is a significant amount of money coming into the state for a variety of rural health-related activities. The second $25 billion is oriented around an application that the state will be submitting through our governor's office for the remaining discretionary amount. And depending on exactly what the criteria is from the federal government, we'll structure that application and identify potential programming for it and hopefully receive a substantial amount of resources there. The tricky thing here is that we don't have that application yet. And the turnaround time on it is going to be pretty soon. So we're going to share with you what we know about what is likely to be expected of the states in our application, who is eligible to potentially receive these funds, and for what types of activities. But we are still in the process of sharing about this, gathering information, and really culminating into a plan and application to submit to the federal government for consideration and pretty quick review. So that's part of what we're doing here today, is wanting to engage, share information, prompt ideas and thinking, and then give you an opportunity to provide feedback and ask us questions. So you'll see here just some of the few highest level next steps in terms of what the plan for North Carolina will look like. There's going to be a significant focus on improving access for individuals in rural North Carolina. There's going to be a workforce element. We, of course, need to maintain and reinforce provider partnerships. And ultimately, of course, the goal is to improve rural health residents, the outcomes for health outcomes for rural residents in North Carolina. I verbally already shared the outline of the timeline, but we could receive the application as soon as this week from the federal government, but we're going to have to turn that around in a few weeks and get that back to the Centers for Medicare and Medicaid Services, and then distribution of funds will begin fairly early in the new year. Next slide. So we'll dive into a little bit more detail here. And some of this is really coming to us from our friends at the federal government. And this is not a slide that we created. This is information that is coming to us from CMS, the Centers for Medicare and Medicaid Services. And this is what they're laying out at a high level for the goals of this program. And I do want to just note that many of these things are things that we've been working towards from a variety of different perspectives for quite some time at North Carolina DHHS. You heard about some initiatives that Kelly was highlighting specifically from within the Division of Mental Health, Developmental Disabilities, and Substance Use Services. You'll hear later from Maggie Sauer, our Director of the Office of Rural Health, which also has a number of initiatives that align and are consistent with these types of activities. But there is still a lot of specificity that we're lacking from the federal government that can flesh this out, and a lot of ideas that we have that fall into these buckets that we still need to refine and help shape out. I do want to specifically highlight that very first blue box, Make Rural America Healthy Again. And now there's a couple of more specific boxes underneath it around prevention, particularly around chronic diseases and behavioral health, both of which are, of course, very important. I know that you particularly find value in the behavioral health emphasis. But I want to say that this is also prompting us to think about what we think in North Carolina as what's the plan to make rural North Carolina healthy, right? How would we structure this in total? And this is not unlike the approach that we took when we laid out the behavioral health roadmap during Governor Cooper's administration to really identify what the primary challenges were in our behavioral health system, and then start to really systematically apply resources to address many of the issues that we had identified. And so I think this opportunity with the funding coming from the federal government provides us that opportunity to do a similar effort, but with a little bit more of a holistic rural health focus. But naturally, of course, there will certainly be a behavioral health element embedded within this going forward. Next slide. So this is information that's really drawn directly from the legislation, HR 1, that was passed. And that's the real detail that we have to work on at this point, in addition to what is being shared through some early webinars and guidance from the federal government. But there were some high-level kind of outlines in the legislation itself that laid out what the kind of required plan components and certain types of activities that would be eligible for funding. And again, not a lot of this is necessarily all that surprising. A lot of it's around access and around investing in technology and preventative medicine and connecting patients to the care that they need. But what this looks like, and if there are kind of specific tailoring of this to certain types of providers, or if there are certain things that are not going to be included, we still have yet to fully understand that based on the guidance that is forthcoming from the federal government, which honestly could be happening at any moment these days. I could be talking to you now and it could be coming down the pipeline. So, but we're very excited to get that information. But again, the lack of detail that we currently have hasn't stopped us from moving forward to have these types of conversations so that we could start to get folks thinking along the same pathway and start to solicit additional ideas. Next slide. There's additionally in the legislation, there was kind of a specific list of providers that were eligible. And again, don't have any additional details beyond this until we get the application itself from CMS. But you can see the types of providers that were included and named. A lot of them are different types of hospitals, but you'll also see federally qualified health centers, rural health clinics, and then there's certainly some behavioral health providers that are specifically named as well. So again, we expect to receive guidance from CMS in the application here very soon. And then we'll be able to refine from there any additional criteria for potential providers and what types of projects that might look like or could qualify, and then how we're aggregating that into an overall plan for the entire state of North Carolina so that we can hopefully attract additional resources coming into the state. Next slide. So this is a website that we have already set up for you to be able to send us feedback, ideas, and suggestions for what types of activities and programs that these funds could go towards. I do want to also say that once the law had passed earlier in the summer, we went ahead and set up, in addition to a portal inviting feedback, we also set up a steering committee within the department so that we had a lot of different functional areas across the department coming together to be able to help steward this application forward, working collaboratively with the governor's team to be able to put the best foot forward for North Carolina. And we can't do that without your feedback. And so that's why we're having these conversations. And as we get additional detail, we'll certainly have subsequent conversations and opportunities for further refined feedback. But we are hopeful that a state like North Carolina, which has the second largest rural population in the state, is well positioned to receive not just the minimum $500 million over the next 5 years, but potentially substantially more, so that we can make really robust investments in rural North Carolina. Next slide. Oh, excellent. Are we moving now to the panel? Wonderful. So we're going to bring Kelly back into the conversation. And we'll also ask Melanie Bush, our Assistant Secretary for Medicaid, to pop on, and Maggie Sauer, the Director of the Office of Rural Health. Now, again, these folks are key to our conversation and within the department to ensure that we're having a variety of different perspectives as we're starting to really go through the nitty-gritty of how we're going to structure this application as we get into additional details. And we do have an opportunity for you to submit questions through the Q&A function here. And so please do that. But before we dive into any participant questions, we do have some questions kind of prepared that we thought would be helpful to kind of pull out some particular aspects of this that we've been thinking about and we've been chewing on, and wanted to give an opportunity to kind of air out some of these thoughts and ideas so that it could help get the creative juices flowing as we approach this really, really important and good opportunity. So one of the things, and this is really open to everybody, but I may ask Kelly to kind of kick us off here, is that there are a lot of things that the department already has underway, a lot of ideas and initiatives that are currently underway. And there's a way that these funds could be leveraged to say these pilots and these new opportunities are working, and this is the way to supercharge it, or we're identifying a gap and this is the way to kind of fill in a hole that we're identifying. And so I was curious as to whether you and Maggie and Melanie had specific models and initiatives that the department's undertaking now that these funds could be used to really double down on some success.
So I'll go. You want to go first? I'm happy to go first. So yeah, great question. I think, the first three things popped into my head when you asked that, Jonathan, and things we've been thinking about. We've already been working on, but when we heard about this funding opportunity, we thought this would be great. So the first is our Certified Community Behavioral Health Clinics, our CCBHCs. So those are actually called out specifically in the federal legislation. And so these are, for those of you that don't know, they're in a strategic plan, so you've heard me talk about them, but we have about 7 of them in North Carolina so far, and they really are, they're integrated clinics for individuals with serious mental illness and substance use disorder. I'm using the technical terms, y'all, but they're really about making sure that those individuals are getting both medical care and mental health and substance use care. And they're great for rural areas. We're working on a prospective payment model, which is really great, again, for rural areas. And so we think that's a good opportunity. Another thing is how we've been using telehealth programs. And I know Maggie will talk more about that as well, but we know that we have a critical shortage of clinicians, period, psychiatrists and psychologists as well in rural areas. And so we do think this is an opportunity to expand some of our telehealth programs, like NCPAL. We are planning some expansion right now to make sure that we're helping primary care docs do mental health and substance use treatment in their clinics. We've got a wonderful psychiatry program, NC STEP, that already does some support to primary care clinics. So we think that's a good opportunity to expand that, but also to potentially think about expanding psychiatric access for some of our mental health and substance use providers. We often do that access into primary care, which is much needed in the hospitals, rural hospitals, but we know that you guys, our mental health and substance use providers, are really struggling to find psychiatrists as well. And we've been thinking through, can we use some of the dollars to get more psychologists into rural areas? And that's particularly challenging, right, for our families with intellectual and developmental disabilities who can just wait absolutely months, just months to get a developmental evaluation. And that's really not helpful. So, and then the third thing I think is, and I'm sure Maggie will talk about this too, is loan forgiveness. We're close to announcing our mental health and substance use loan forgiveness program. We are optimistic that it'll help us recruit more licensed professionals across the spectrum, right? Master's level licensed in mental health and substance use settings, in primary care settings, in rural areas. And so, whatever we could do to expand more workforce in rural areas would, I think, be really helpful. So those are the first three that came to mind.
That's great, Kelly. Thank you. And that I did think it does tie into some of the key initiatives that I think of with ORH, the Office of Rural Health, and the work that Maggie and her team are doing. So it's an opportunity to even bind those things a little bit closer together.
Yeah. So, Jonathan, I guess I'll jump in. I think North Carolina has been moving towards trying to create a more connected opportunity across the state, and that's been in partnership with DIT, the broadband office and many things. I will say that in North Carolina presently, if we're talking about braiding and building on things, we have a long kind of history with the NC STEP program, which is out of ECU. That program predominantly had been something to provide psychiatric support for many of the hospitals across North Carolina. I'm really happy to hear and know that they also now do a lot of support for community-based organizations. So, we're talking about local health departments, we're talking about some schools, other places that need support, need psychiatric support to really integrate the services. Sorry for the background noise. To provide that support. And what I mean by that is we've had some clinics now that are able to specifically include behavioral health support because they now integrate that piece directly into the clinic. So there's a whole person care. So that's been, I think, another really important part of all of this. The General Assembly provided $20 million last year for telehealth structural grants to help primary care and maternal health homes establish new resources and supports. And so I think, if you look at building on some of those opportunities, and, to Kelly's point, the North Carolina received, again, from the General Assembly, a $50 million directed opportunity around providing loan repayment and other services. And so I think it's incumbent on us, which includes behavioral health and nurses and so on. It's really, how do we really help blend, support, and braid these opportunities to be more focused on the needs in communities and to support what Jonathan said. Community support is so important. All of you know what your communities need, and that's why your feedback is so important. So if we can begin to look at, North Carolina is not the same from the east to the west. So it's really important to begin to think about how those different locations may have different needs based on the assets and the needs of each community.
Well said. Melanie, happy to have you chime in here. And I also have another question that you're, I think, probably best suited to offer an answer to. which is, you know, how this rural health transformation program fits into the context of the overall Medicaid landscape. And, you know, there was a lot of stuff in HR1. So there's a lot of work that the Medicaid team is doing here in North Carolina and around the country. And so maybe give us a little bit of context here for how this kind of fits into what's going on.
Yeah, thanks, Jonathan. Melanie Bush, North Carolina Medicaid. So HR1 does have considerable impact on the North Carolina Medicaid program. Some of the changes related to provider payments and our state-directed payments will result in a loss of funding of about $22.5 billion over the next 10 years. Most of that funding loss is to our hospitals, and of that, about $3.7 billion is coming out of rural hospitals. So this rural transformation fund is not necessarily going to replace all of that funding, but it is a bridge to help us stabilize the rural systems. And we are going to be looking to use it in innovative ways where we can braid funding, as other folks have already said, to support our rural hospitals and keep those doors open. We are looking at different funding mechanisms, reliable value-based payments that would sustain care, really looking for feedback and input from the community too about ways that folks think would be best served through the Medicaid program. But our priority, of course, is to serve the 3.1 million North Carolinians that rely on the Medicaid program, and to support all of our providers, because without our providers, we cannot serve them. And so, again, this is not going to replace the funding, but it will help us bridge and stabilize some of the rural health funding.
Yeah, and it's a good point, right? I said it up top that the funding is for a 5-year period, so it's inherently time limited, right? Regardless of how much money the state ultimately is allocated. And so the sustainability of what is being funded is an important component. And I think that from what we've been hearing from our federal friends is how can you structure these dollars to help shift a model, right? Or invest in new technologies that actually open up services, right, for folks that may help generate more revenue for the providers and increase access, right? And so those are the kinds of things that I think that we're trying to think through. And so it's not without its challenges, as some recurring funding is being lost as a result of HR1, but this does offer us an opportunity with some potentially really valuable and flexible dollars going towards some kind of important initiatives there. Fabulous. I'm going to, and maybe Maggie might be best to take an initial stab at this one, but I'm curious as to how you would articulate the most pressing challenges facing kind of rural hospitals and providers, and how these funds could potentially help address some of those challenges.
Yeah, thanks, Jonathan. A couple of the issues I think that we're grappling with right now is many of the webinars and things that we have participated in have said that the funds needed to be used to sustain a transformation after the 5 years. And they have inferred that it's not meant to be used to simply replace Medicaid cuts or help with the bottom line, so to speak. We don't know what that looks like right now, but I know that that is something that is top of mind for everyone. I do think that when we look about creating an infrastructure that needs supported into the future, we can look at some of those technology supports that allow people to talk about what their work means in improving people's health and using some of the funding to help do that. I know I've had discussions with folks about just access to care, and I think it's going to have to be a blend of those things, which include telehealth. We've had discussions about mobile clinics, and things that really can create additional access to care. And that's where, providers in people's communities, we're probably looking at something that looks a little bit different instead of just having people located specifically in the community with their patients. That's the gold standard. That's what we all would like. That's what we all want. And yet we still have issues with people just getting access to a primary care provider, let alone specialty services. So I think that those infrastructural issues and having real conversations about how to really meet the needs of the community, doing things perhaps in a little bit different way, and being able to measure what it is that we've done. And we know cost and efficiency are the other things that they're looking for in these applications. So we've got to keep doing the great work we've done, and we've got to build on that so that we have, after 5 years, a sustainable infrastructure that creates health.
Kelly or Melanie, anything to add to that?
I'm going to say, kind of just adding to what Maggie said, which I agree with completely. I think, Maggie, as you were talking, it made me think about, we just launched the mobile opioid clinics last month, which is really exciting. And we hope by the end of the year to have 10 of them. And that's a real opportunity to have those mobile units partner. Absolutely. They can show up at local health departments. They can show up at FQHCs. They can show up at churches. They not only provide a full complement of medications for opioid use disorders, they also have nurses on staff. They have counseling on staff as well. I mean, so there's just a real opportunity to use that, to get more of those trucks out there and to really partner and bring healthcare to people. And I would say too, I think, Maggie, what you said about having to deliver healthcare in a different way. What's really interesting about mental health care in particular is many people really warm to virtual care, like really like it. And they really, really like it. And I know there's folks that have some discomfort with it, but it's one of those things that I think we can really lean into. Folks have to go to a primary care site to have medical care. If it's got to be a must be, that's great. Let's bring mental health care there to the clinic. Let's train those physicians to administer medications for opioid use disorders. Let's bring virtual care, virtual psychiatry to the clinic, right? And I think that we've shown here in North Carolina that works really well. People like it as well. So why not use this as an opportunity to try to embed those kind of supports in places, whether it's a rural hospital, a primary care clinic, where people are going anyway.
Yeah, and I'll just add that, our experience with COVID, of course, helped accelerate our transition to telehealth. And we have kept most of that in place because it was so successful. And so we're looking for ideas like that will help the rural providers in different and new ways. And hopefully we don't need a pandemic to get us accelerated.
Yeah, indeed. We can use the positive carrot here of the money from the Rural Health Transformation Fund as the motivator here, as opposed to the stick of a pandemic. And y'all are kind of already going down this path already, but how do these funds and the criteria that we're aware of at the moment, and it'll get again refined through the application, kind of align with the goals of the department? Because I've been at the department 6.5 years now, and behavioral health and really elevating that as a primary concern and integrating it fully into kind of a holistic delivery of care has been a huge emphasis over my tenure at the department. And I know it's exciting to me because I think that as I look at it, it feels like it's an extension of the work that's already underway here. And so if you maybe say a word or two about how you perceive it as aligning.
Yes, it absolutely does. So a lot of the ideas were things that we have started. We started in the last administration, where behavioral health integration was an incredible priority for the department. Many of you remember the $835 million that the system got for improving everything from our crisis work to supporting individuals who are involved in the justice system to workforce. to integrated care. And through some of those dollars, we were able to do things like start and support the collaborative care model, where psychiatrists and social workers are supporting primary care. NC-PAL was funded. And so again, that's psychiatrists providing consultation to primary care doctors. And certified community behavioral health clinics. That's really on the other end of the spectrum. It really is making sure that at a site where individuals who maybe think about their healthcare through the lens of maybe mental health or substance use, going to go to that provider, that their physical health care then is brought to them there. So that was started actually with some federal funding as well. And so those initiatives have been going on for multiple years now. I think so. This is a really opportunity, and we've learned a lot from them, and they're keeping going for a reason. So this is a moment, I think, to expand those things. But and of course, I mean, I'd be remiss not to mention tailored plans, tailored care management. Think about so much that we've invested in so people get whole person care. So big system things like a tailored plan, and then other initiatives very specifically at integrating at the primary care level, at the hospital level, and then actually now in the mental health and substance use clinic. So many of these things started years ago. So that would just be, I think, increasing that integrated care vision, or continuing that integrated care vision with these dollars.
Well, and that was actually my thought too, in the Medicaid space in particular.
Yeah.
The whole person integrated care with the launch of tailored plans. What was that, just last year? Tailored plans
Last
went
July.
live. And mental health parity and other things in the Medicaid space. It feels like there's an opportunity to really kind of be a force multiplier in the space.
Absolutely. I will just say that CMS has actually highlighted, and I think Jonathan mentioned this on a previous slide, the importance of behavioral health. This funding is not just for facilities, it is for providers across the board. And so we hope to be able to leverage these funds to support them in that way. Tailored plans have been revolutionary. We're very impressed with how they are performing and the services that folks are receiving. And we hope to continue that in the future and provide that whole person care at every point in the state.
Hey, can I put in my plug here? Thank you for
Sure.
saying that, Melanie, just because I said it at the top of the hour, but I always want to remind folks, because we know in our community, like our folks, right? People with mental health issues, intellectual developmental disabilities, substance use disorders, just have the most complex medical issues as well. And so
Yes.
really getting access to primary care, to specialty care, getting your diabetes, your COPD, your blood pressure, your heart disease managed well, is just really, really, really important. I think that's part of the beauty of tailored plans. But that's, when I think about if a lot of this money goes towards primary preventative care and chronic health management, that's a huge win for our community, because that's us. That's us who are pretty darn physically sick, and we need to make sure that we have access to those services in rural communities.
Just, I guess one thing I would just also tag on real quickly is I see a lot of questions in the chat about, or in the question box, about rural. How are we defining rural? What are rural health facilities? I will tell you that the legislation is very specific about how they are looking at defining what those rural health facilities are. We are very lucky, again, building on some of the things we have in the state. The UNC Shep Center has access to all kinds of data. Our team, hospital team, has access to all kinds of data. But what the Shep Center is going to be doing is creating a list of all of those listed entities in North Carolina that qualify. So doesn't mean you can't do other things. It just means to understand what the guardrails are around what that looks like. And certainly I see the questions about, paying for community-based organizations and how, and quite honestly, we've got to wait until we get further guidance from the Centers of Medicaid and Medicare Services. I will tell you, though, that your team here at DHHS, in every meeting that we've had and had an opportunity to provide feedback, not only through this, but through other national organizations, has said how important community is to making sure that these activities will work. So, while we're talking about what we know and what we don't know, let me tell you, people behind the scenes have been trying to influence and help people at CMS understand the needs of North Carolina. So I feel I'm proud that we've had the opportunity, and I'm really proud to get the feedback we've gotten here. You have cheerleaders through DHHS rooting for us out there.
Absolutely. And there are questions I want to pivot here now to try and start addressing them. And maybe Rachel can help, our colleague Rachel can help flag for us some key ones that seem to be standing out. I've been trying to keep an eye on it, but as we've been chatting, haven't necessarily done a great job at that. So happy to have you flag a few for us to tackle specifically.
Sure. Rachel Cooper, I'm a project manager across our health portfolio here at DHHS. And I think we got a lot of questions around the definition of rural and what does it mean to be a rural health facility. I think we touched on that earlier. Any other comments on sort of who qualifies or how we're thinking about what is a rural health provider?
Yeah, and that's where there are some pretty precise definitions currently in the legislation, and then we expect the application itself to provide us some additional specificity there. And so we don't 100% have the answer to that question, but I would anticipate that our application would likely start off by defining the scope of the rurality of North Carolina in total, because I think the need in North Carolina is often misunderstood because North Carolina is a very populated state. They don't understand that we aren't dominated by really large cities the way other states are. And so our large population is actually in very rural locations. And that means the need for access, right, and the attention to these issues is quite great. And so we're going to have to be very intentional about telling that story. And sometimes the definitions work out fine and sometimes they don't. And then we're going to have to probably tell that story as best as we can.
Yeah, we're second only to Texas in the size of our rural population. And Texas is obviously geographically much larger than the state of North Carolina.
I think another question that came in was around sort of balancing funds. So we'll have to make some decisions around funds allocating between hospitals, clinics, behavioral health providers. Do we have any early thoughts on that?
I'll take a stab real quick and say, let me just say the need far outstrips the amount of resources that will be coming to the state. Even if we get substantially more than the $500 million baseline over 5 years, there is a significant need. And in some ways, the need is growing because we anticipate substantial funds being lost as a result of other provisions of HR 1. And then, of course, the population is growing. And so we have a lot of drivers of the need in North Carolina. And so I don't think that we are at the point yet where we kind of have this distribution in mind of how the resources should or could be allocated. We are still very much in that place of send us your ideas. Let us make sure we're getting that feedback so that we're not missing anything. And so we have this and other opportunities. We're baking this into presentations and engagements that are existing in other parts of the department. And so we are very interested in hearing your thoughts and ideas. We have some, but we welcome others. And so there are, I think, other questions embedded in the Q&A here about, well, are you doing this or can this be done? And the question is maybe all of it, but we have to we're still at the kind of widest part of that funnel right now and haven't gone through that winnowing period. But I welcome any of my other colleagues' thoughts there.
Yeah, those are such great points, Jonathan. I would also say that our office has been engaged in these regional meetings across the state and getting feedback. And that kind of goes to how are we seeking feedback and trying to give people those opportunities. But I would also say that this is an opportunity as a state to begin to think, and there's been some comments about regional, how do you think about the health of your community, not just one organization. So if you're able to think collectively about how the opportunity to work together can affect the outcomes of your region, you know, that's going to be important. It's really hard, I know, at this point to be thinking about, bottom lines and so many things that are affected by it. But I do think that the infrastructure support that they're going to be looking for is not, again, just for one entity, but how do you really look at across the region or across an area at supporting the health of people in that region. And so, as I support everything that Jonathan said. It's not easy, but at the same time, I think it's not just about paying for one thing. It's about how do we do this together.
And I'm not the decision maker, but I'm a big fan, as most of you know by now, at funding with obligations, if that makes any sense. So like, as Maggie said, a region needs services. So if in a region we have already funded a CCBHC, how can we use this money to make sure that CCBHC is really connected to the rural hospital there, to all the primary care clinics, right? Like how can we potentially use the money to foster partnership or to cross-pollinate through telehealth? I think there's some really good opportunities there. And I don't think, that we know that communities are beautiful and different here in North Carolina. And I don't think that everyone has to do it all the same way, right? I do think we have limitations on how much creativity we could actually support, right? But so I do want to say that to like temper my comments about the beauty and uniqueness of communities. But I do think the funding guidelines itself gives us a good sense of like communities should have X, right? And when I think about for our community, I think that means it's just important that we lift up. Every community needs a source of mental health care, substance use services, period. Whatever setting that comes in, it's got to be there. And people with IDD, mental health and substance use, need primary care and chronic health management. Like those things have to be there. And to me, those feel non-negotiable. They may look a little different in every community, but those things have to be there. Rachel, can I comment on the IDD question that's come up? Because I think it's like really important. It's come up a couple of times. So, because you've all heard me, I know you've heard me. I've said mental health and substance use many, many times, right? And I think that's really important. And remember, people with intellectual and developmental disabilities also have mental health and substance use needs. So know that. But I would say, like, based on my last comment about communities needing mental health and substance use, I would say for our folks with IDD, when I'm thinking of these dollars, I'm thinking, how do the mental health and substance use services support people with IDD, right? If that's what we can fund, because we probably can't fund community-based services as much as we'd like to. But how is the healthcare that this may fund comprehensive? So one of the most obvious ways is through the NC-PAL program. I know most of you don't even know this, but some of you do. Like NC-PAL, psychiatrists are there to support primary care to meet the physical healthcare needs of individuals with intellectual and developmental disabilities. We know that we do not have enough primary and specialty care that understands the unique needs of people with intellectual and developmental disabilities. I know it. So how can we beef that up across the state? We can't have, I'd love to have 100 specialty practices, one in every county, but it's just not doable. So how in rural areas where we know we're hard pressed to find good primary and specialty care, how can we really use something like NC-PAL to make sure that we've got a coach and support and we're training those offices to meet the unique needs of people with intellectual and developmental disabilities? So again, I don't see any myself. I mean, maybe Jonathan will tell me I'm wrong. I don't see money for HCBS services, but that doesn't mean we forget about people with IDD. Not at all. It means everything we do should be thinking and how, because these are unique, important members in our community, how are we using this money to meet their physical healthcare needs, mental health care needs, et cetera.
Yeah, and access is an important theme here, and access can be defined in a lot of different ways. And so I think that that is something that's kind of foundational to our thinking here, is that you need to maintain and expand access. And sometimes that's a physical place, and sometimes it's not a physical place, and sometimes it's leveraging a physical place to do more to meet a population's needs that are currently being unmet. And so there's just a lot of different ways to slice that.
I was actually thinking just of that, and I was thinking actually about our tailored plan catchment areas, and we have 3 of the 4 tailored plans are in largely rural areas throughout the state, and we have network adequacy requirements that are usually based on time and distance, but we're really trying at Medicaid to work on realized access instead of just paper access that says that you do have access based on time and distance. So that's something else that we're going to have to take into account and hopefully use some of the fundings to increase realized access through telehealth or other means.
I think we might have to stop there in terms of questions from folks. We have about 5 minutes left, so I want to turn it back to Kelly for any closing remarks.
I just want to thank Jonathan, Melanie, and Maggie for coming. I don't know if Brianna, can you take a minute and find that slide that says how folks can give their feedback? Could you pull that slide back up again? I want to make sure that folks have that. I'm sure we sent it out in Hot Topics. We'll send it out in the Hot Topics again. But remember, this was our intent today was really just to get you. So go back to the last slide that Jonathan did, Brianna. This really was to let you guys know, you're very, very important. So when we talked about what standing groups need to hear about the Rural Health Transformation Program, who needs to hear about it and where do we need feedback, you're obviously an important group of people. So that's why you got really important people like Jonathan, Melanie, and Maggie come today, okay? We wanted them to explain the program to you, and we wanted to get out this link. So there's a website that explains it more, and a link and a QR code where you can actually provide some feedback. What Rachel told me was the feedback we've gotten so far, and this doesn't surprise me at all, y'all, the feedback we've gotten so far from the whole state of North Carolina, the greatest amount of feedback has come from our community. What a surprise, y'all. I'm totally surprised. So keep coming in with the feedback. It matters very, very much. And I saw some comments in the chat about how are you trying to get feedback from rural communities and from CFAC. Y'all know what our CFAC is, right? Our State Consumer and Family Advisory Council. Well, absolutely. I think Deborah Farrington will be coming to the CFAC to talk about this program, but your feedback matters. So if you're a local CFAC, you're a state CFAC, if you're a family community member provider, use those links to give feedback. And we'll be taking every opportunity we have with natural moments that we already meet with you in the community to explain the program and to get some feedback. But no, this is early days in the thinking, right? This isn't the only time you're going to hear about it. So give us your feedback, and as ideas generate and germinate, we'll be sharing them with you for additional feedback. So thank you all for coming today. Want to make sure, Jonathan, Melanie, Maggie, any closing remarks from you all?
Just always appreciate the time and intentionality of this community in particular. And we're in it with you and want your feedback. So please chime in.
All right, y'all heard that. You heard it from Jonathan himself. So thank you all for coming. It's hard to get important people so much of your time. So really, really thank you all. And get the feedback in, y'all. We had more questions that we can answer today, but as always, we will look at those questions and find ways to incorporate that kind of information into other meetings that we have with y'all, okay? All right. Thanks so much, everyone. Have a great week. Bye.